Friends, good afternoon to you all. We are going to start our course on masterclass on IOL power calculation. And we have been giving the same course at AIS for a couple of years. And we have a brand new faculty this time. And all of them are very experienced in their fields and they take keen interest in field of IOL power calculation. So we have Dr. J.S. Bhalla. I would request the faculty members to come and take the stage. Dr. Charuta Puranik, Dr. Vardhaman Kankaria, and then Dr. Mohan Rajan. He will make, he will give a short cameo whenever he comes here. And so this is the roadmap of our presentation today. So I'll start off with the best practice SOPs for optimal refractive outcomes. Dr. Bhalla, contemporary tools, strategies to optimize toric outcomes. Dr. Charuta will talk on incorporating cutting-edge technology in IOL calculation. Vardhaman on recent developments in post-refractive surgery situations. IOL power update in common posterior segment pathologies is the topic that I'll deal with. And I will also talk a little bit about long and short eyes. And then Mohan Rajan will talk about, I think, about flags in difficult situations. So you please understand that each title that is given here is a topic by itself. So we will not be able to cover the entire gamut of, entire range of the issues that are included in a particular topic. So we'll try to be as practical as possible. And at the end of the discussion, at the end of the presentations, if time permits, we'll have a short discussion. So I'll start off with the first topic, that is best practice SOPs for optimal refractive outcomes. In this presentation, I'm going to share with you the protocol that I follow for IOL power calculation in routine eyes and in most of the difficult situations. So this is actually not a fixed protocol. It keeps on changing depending upon newer information, more experience that I gain. And this is a very happening field. If you take every issue of the peer review journals, each issue will have multiple articles as you see here. So which means a lot of things are happening and we need to be aware of what are the new things that have come up, what are the new experiences that our peers have shared through these publications, and whatever is effective, whatever is practical in our setup, so that needs to be incorporated in our IOL power calculation exercises. And we being the surgeons have to determine what is the best for us, and this has to be passed on to the team which does the IOL power calculation. So where do we stand today? There was an article by my good friend from Italy, Giacomo Savini, where he reported his results on IOL power calculation in routine eyes, measured using a swept source OCT-based optical biometer, a high-quality optical biometer. And he showed that 88% to 90.67% of the routine patients, when they are worked up with the newer formulas, should rank within a refractive prediction error of 0.5 diopters. So if you are not reached that level, you have a long distance to cover and you have to do your basics properly. And those of us who have already reached this level of accuracy, what next for us? So many people feel that perhaps we have reached the limit. Axial length calculation measurement has become very precise and accurate. There is some issues still pertaining with the keratometry. We still have to go a little distance with precision as far as keratometry is concerned. And there are certain uncertainties that we cannot do anything in our surgical steps. For example, the discrete IOL power steps, we have no say over it. Manufacturing, labeling tolerances of the intraocular lens. Effective lens position is again a bugbear. And we are increasingly realizing that angle kappa and ocular biomechanics also play an important role in IOL power calculations. So a brief word about this, there's ISO standard for labeling tolerance. So, ISO allows the companies to have some amount of inaccuracies in the power that is printed on the lens package. So if a lens is less than 15 diopter, then there is variation between minus 0.3 to plus 0.3 diopter. And for higher lenses, for thicker lenses, it could vary from -1 to +1 diopter. So the lens that you get, that is actually may not be the precise power. It lies within that range. So that can result in some inaccuracies in the postoperative prediction error particularly for higher, for thicker lenses for higher power. And then most of the manufacturers come up with steps of 0.5 diopter, 20, 20.5, 21. And for the extremes of the eyes, it could be even 1 diopter. So there again, you may not get the desired lens. Whatever lens you are opting for, you may not be able to get that particular lens. All of us must realize that IOL power calculation is not something that one does just before the cataract surgery while working up the patient. It is something which transcends in all stages of the patient's surgery experience. Preoperative period, intraoperative, the surgery has to be done properly, rexis has to be well centered, and postoperative period is where you do the auditing. And you can put it for 10 minutes. You have to do the auditing to find out whether whether you're able to reach the target refraction. If not, how far you are from it, and what are the modifications you have to make in your protocol. We have known for last 7-8 years that ocular surface plays a very important role in IOL power calculations for particular measurements. So first thing that we look for is the presence of ocular surface disease, and if it is present, it is the biometry is not done. We try to use lubricants to optimize the ocular surface, and then the biometry is repeated after a few weeks, and if necessary, even after some more weeks, so that we can accept only 2 consecutive repeated values. Then we know that our biometric evaluation has been pretty precise. We must employ a nil touch technique of biometry. Biometry should be performed on a virgin cornea. So if a patient has already undergone gonioscopy, apprehension tonometer, dilated evaluation, it's no longer a pristine cornea. So in that situation, it is a good idea to bring the patient back on another day to perform the evaluation. Most of the biometry is performed without the pupil being dilated, but certain situations for ultrasonic biometry as well as for optical biometry, like this was published in JCRS with biometer was IOL Master 700. About 8.52% of the cataract surgery patient did not give good quality measurements. So once these eyes were dilated, most of them could give a good measurement. So there is some need for, we need to dilate certain patients to get a high quality measurement. But then there is another side to this story. Once you dilate the pupil, there are changes in the biometric parameters that happen. And these biometric parameters which you obtain after dilatation may alter the IOL power calculation to that. In fact, in about 20% of the patients, it could result in a myopic error of 0.5 to 1 diopter. So this is something which is discussed with the patient before the biometry is done, before the surgery is done, and then the patient is taken up. This is what all I use for my biometric evaluation. I use a topography. This is must for toric IOL and for higher the newer generation intraocular lenses. Eye trace also helps you to rule out certain cases for these advanced technology lenses. Now, once you have got very precise biometric parameters, you need to use a particular good formula. So these are the formulas we have been using for last couple of years: Barrett Universal 2, Hill RBF, Olsen, and then there are new kids on the block: Kane formula, EVO, Panacea. Beginning of this year, there was another classification. I think it looks very, very intimidating, but it is a very systematic classification. I'm not going to go into it, but so there are a lot of formulas that are available, and I always do an online calculation. I don't depend upon the IOL formulas which are there in the particular biometer. So online IOL calculation means you can calculate your lens power using all these online calculators, and that means you can get multiple results. And also the updates are incorporated in the formulas by the formula writers as soon as the updates are ready. So you have a very up-to-date formula, unlike the formulas which are there in your biometric devices, where the updates may not be, A constant may not be updated, or other updates may not have been incorporated. So go for an online calculation. And these are all most of these calculators are absolutely free of cost. I'm not going to spend much time on it. Toric formulas and SI calculators. Post-refractive calculators, I think Ascaris calculator and is most complete. Barrett and Pearl DGHS also. So this takes care of all your post-refractive surgery requirements, including post-RK eyes. So a word about Hoffer Q. Many people have been using Hoffer Q, but in fact, in my personal discussion with Ken Hoffer, he told me that Hoffer Q is something which he wants to people to abandon, but then people won't do it. So he updated this formula of our QST, so it has updated algorithms including artificial intelligence. It has taken gender into account, and there is preoperative anterior chamber depth, and this is also incorporated in the ESRS site. I'll come to it later on. So my go-to formula is Barrett Universal 2. It is there in the APACRS website. It gives you the entire Barrett suite. I actually use a Barrett toric calculator for all my routine cases. And then Barrett TrueK formula and Barrett TrueK toric calculator for post-refractive surgery, eyes. So all your IOL power requirements can be satisfied by Barrett suite of formulas. And Hill RBF formula, of course, is an artificial intelligence-based formula. It is available in Warren Hill's website. It is also available at the ACRS website. You have the Hill RBF version 3. But still, it may not give you the full, some of the extremes of the eyes, you may not get proper, values. It may give a red flag. So then of course, I would also be using the other calculators and find out and compare in extreme situations what should be the IOL power that I choose. Kane formula has been doing extremely well. The non-toric version, toric version, and recently the keratoconus version has also done extremely well. And this is proved by multiple studies that have come up in the peer review literature. Second eye enhancer is another feature which has come up in the Pearl DGS calculator. This is something which I want you to be aware of, and I use it extensively. Out of the cataract societies, European society was the only one which did not have an IOL calculator. So 2 years back, they came up with an IOL calculator, and for non-toric lenses, there are 7 modern formulas that can be made use of, so to get your IOL power. So here it is very simple. You just input the data in the fields only once, and this website on its own approaches all these 7 calculators and gives you the result in one printout. So for example, now say if I choose a 16.5 diopter for a particular formula, Barrett formula, so I have an idea as to what is the prediction error shown by, refractive error shown by the other formulas. So previously, I had to deal with multiple printouts, different formulas, and it was quite cumbersome and it was quite laborious. So this has been sorted out by the ESRS calculator. And for the toric version also, ESRS calculator uses these 4 formulas, and it is again proved to be very, very effective. Another strategy that I use, for better prediction for the second eye. First eye has been operated, second eye is being taken up. So if there is a residual refractive error in the first eye, so I would wait for about a month or 2 to make sure that this is stable. Then I would tinker with the IOL calculation in the left eye, so that on the fellow eye, the second eye to be operated, I would use about 0.3% of the refractive error, so refractive surprise that was seen by changing the power of that eye. So as I mentioned earlier, second eye enhancer is available in Pearl DGS calculator. Increasingly, we have realized that the gender is playing an important role in these IOL power calculations. Barrett Universal 2 is most accurate for males rather than females, and other formulas are simply more accurate for females than males. And these gender differences are more pronounced at extremes of anterior chamber axial length or anterior chamber depth. So friends, and you must realize that the cutting edge instruments and devices play a very important role. You must use the current formulas. Lens constant optimization is also important to a large extent. But at the end of the day, you are in charge, so you should work up your patient properly, use appropriate measurement devices. Anything that comes up in the market makes a lot of noise, may not be the best device. So you be very judicious in the selection of biometric devices that you use, and work with properly optimized lens constants, and strive to use all available resources to their best advantage. So this is the SOP that I follow for all my IOL part for my cataract patients. This has given me good results, and this is quite variable. It keeps on changing, maybe every few months, depending upon my accumulating experience or the information that I learn from the journals and from my peers. I keep on changing. So thank you very much for your kind attention, and I would request Dr. Bhalla to take the stage. Dr. Bhalla will be talking on contemporary tools and strategies to optimize toric outcomes. Dr. Bhalla comes online. comes on the screen.
Sir, as you had showcased, it was a beautiful presentation, very comprehensive. About the gender, let's say, influence on the biometry, what do you think is the reason for the same?
Why the gender plays some role?
Yeah.
Yeah. So this is something which has been referred to for the last couple of years. It may be something to do with the scleral rigidity or ocular biomechanics. Exact reason I really do not know, but other than ocular biomechanics, I cannot think about any reason why gender should play an important role. But it is seen only in the extremes of the eyes, not in the standard powers. So most of the newer formulas have the gender factor incorporated in the calculation.
They have gender factor now incorporated in the formula.
Yeah.
Okay, that's interesting.
Yeah, I think Kane formula, they mentioned something that in extremes of the eyes, they've found that the females have slightly longer axial length and more steeper cornea. That was only in the extremes.
So Barrett formula has less bias for females.
Yes.
And all the other newer formulas are more accurate for females.
Yes.
Interesting. Perfect.
Thank you. At the outset, I'm thankful to Dr. Arup for including me in his this prestigious master talk. I'm going to talk about strategies to optimize toric outcomes. We all know that in patients undergoing cataract surgery, there is preoperative corneal astigmatism of more than 1 diopter in 33%, more than 1.5 in 22%, and more than 2 in 8% cases undergoing cataract surgery. And the success of toric IOL implantation depends on accuracy of preoperative planning, intraoperative alignment, and postoperative management. And preoperative planning includes, like Dr. Arup very nicely pointed out, accurate biometry, corneal astigmatism assessment, ocular surface optimization, and please use modern calculators like Barrett toric, Kane toric, or the online calculators. And the patient selection should be very good. Avoid toric IOLs in irregular astigmatism. It is debatable in keratoconus, and always under promise and over deliver. And please also check higher order abrasions. So preoperative assessment includes thorough examination of lids. Please see whether there is MGD or blepharitis. If it is there, treat it. Dry eye ocular surface evaluation should be done. Optical biometry plus corneal tomography and macular screening by OCT should be mandatory. And precise biometry should include optical biometer, the latest ones, the swept source based, but don't be disheartened if you don't have them. There is no access to optical biometry. You can use immersion A scan, and you can have multiple keratometry readings, preferably on 3 devices where you are not getting consistent keratometry readings. Always, there are some acts of commission and omission which we should always be careful about. Like if there is, you're doing keratometry, you use appropriate formulas, inaccurate placement of IOLs, and acts of omission also have to be really given importance. Why do we get different readings with different keratometer? Because we know that cornea has a prolate shape, and if you measure closer to the center of the cornea, you're going to get higher readings, and if you are further away from the center, you will have slightly lesser readings. So integrated keratometry is important, where it has been shown and published that the median anterior surface keratometry value derived from 3 different devices leads to better accuracy. So we all are aware that 1 degree of misalignment leads to 3.3 degree decrease astigmatic effect, and 30 degree misalignment leads to total loss of toric correction. So if there is history of dry eye, please use lubricating eye drops 10 to 15 minutes before doing keratometry. Optical biometers are accurate, but if in doubt, you can, like I mentioned, take K from different instruments, compare both eye readings, and verify steep axis again in the topographic map. How much does astigmatism of the posterior corneal surface matter? It is important because majority of the people naturally have WTR, posterior corneal astigmatism, but it translates to negative WTR, so it becomes against the rule astigmatism. So that implies that if there is ATR astigmatism, we have to be more aggressive in treating this compared to with the rule astigmatism. Does the astigmatism measured in the manifest refraction matter? Conventional wisdom says to disregard, but it is important because it gives us some idea about the posterior corneal astigmatism, and then this value can be useful. So it is important to calibrate your machines weekly, because if you don't calibrate, you may land up with some errors. Then check the level, because if there is slight tilt of the head during optical biometry, this can lead to changes in the steep meridian axis measured using optical biometer. And steep meridian, it was found, generally shifted to the direction of the head tilt. Like here, once you corrected the head tilt, the axis changed from 72 degree to 82 degrees. That's a significant error which would have accrued if we had not paid attention to this. Remove outliers which are highlighted by the machine to improve measurement accuracy. Does ocular surface disease or dry eye affect biometry? Yes, it does, because it has been found that dynamic fluctuations in the anterior corneal surface can cause irregular astigmatism. Tear film instability can cause higher order aberrations, and poor repeatability of IOL power calculation can lead to post-operative refractive surprises. So please optimize your ocular surface pre-operatively by using tear supplements, anti-inflammatory eye drops, or if required, immunosuppressive drugs like cyclosporin, and treat blepharitis and meibomian gland dysfunction by the appropriate treatment if it is required. This slide shows that biometry done before and after dry eye treatment led to change of IOL from T5 to T2 just by simply treating dry eye of this patient, because he had significant dry eye. So we treated this patient for 1 month. Measurement errors can be in keratometry, can be if we perform keratometry, should be performed before putting any drops. It should be done on virgin eyes. And stop contact lens prior to the measurement. It is said for RGP to not to be used for more than 2 weeks, and soft at least 1 week. And in biometry, perform biometry before applanation and dilatation. But Dr. Arup showed that there is controversy regarding this, like he showed some papers from publications in the JCRS. Which IOL formula? I think I won't cover this, because this will be covered by the subsequent speakers. So online calculators are refining biometry for toric IOL is equally important, and we should also calculate our SIA. What we can do is the data should be a data of 20 to 30 cases regarding incision location, incision type, incision size, pre-op and post-op K. 20 to 30 cases should be fed into this website, and that automatically generates your SIA. Effect of incision size in very small astigmatism does affect the choice of toric IOLs. And please compare the biometry of both eyes. If one eye is showing a toric requirement and other non-toric, you can recheck and repeat your keratometry and remove outliers in the measurements, if any. And so why is tomography important, better than topography? Because it measures posterior corneal astigmatism also, which influences which toric IOL model has to be used. Like in this case, initially it was showing 0.86 right eye WTR and 0.93 left eye. But once we incorporated the posterior corneal astigmatism, it shifted and the choice shifted from non-toric to toric. So pre-operative marking for toric IOL is important. It can be done with slit lamp marking, gas bubble marker, or you can scratch with gentian 26 needle and stain with trypan blue or gentian violet, or there are now smartphone apps also available. So what is better, manual marking or image guided? It was found that slit lamp marking method, about 28% of toric cases had alignment error of more than 5 degrees. So image guided method definitely helps, but if you don't have it, you can still practice your toric IOLs by refining the accuracy with the practice. So this is intraoperative overlay, and display, what you can do is display the toric IOL printout in the OT with steep axis. Per op cornea should be dry at the time of marking, and adequate rexis size with 1 millimeter overlap is there. So these are intraoperative strategies which should be practiced. And I'll just So accurate axis marking, intraoperative aberrometry, if required, can be done. Proper wound construction, and thorough removal of viscoelastic even from behind the IOL, and precise toric alignment is very important. And final confirmation is after pressurizing the anterior chamber, but not pressurizing, not over inflating, because that can also cause some rotation. Rotate the IOL clockwise till it is just 20 degrees short of the marked steep axis. Remove OVD thoroughly, align the toric marking of the IOL to the cornea marking. Don't overinflate the bag. So post-operative refractive surprises, these are some of the causes. It can be pre-operative, intraoperative, or post-operative. And the misaligned toric IOLs what it causes is, it causes you decrease in astigmatic correction, rotation of the astigmatic meridian, change of the refractive spherical equivalent, and the optical quality is also compromised. So early check within first week is important. Rotation management, if misalignment is more than 10 degree, please consider early surgical alignment, ideally within 1 to 2 weeks, and address the residual astigmatism and choose toric IOLs with proven rotational stability. So in summary, what I'll say is that pre-op work is very crucial, because well started is half job, half done. Optical biometry adds precision and comfort, but it is not indispensable. Conduct biometry measurements before applanation or dilatation. Calibrate your machines regularly. No head tilt on optical biometer or keratometer. Remove outliers and look keenly at the flags in the acquisition of the pre-op data. And consistent post-op evaluation of uncorrected visual acuity, refraction, keratometry should be done to optimize the outcomes. And please always under-promise and over-deliver, and explain the pros and cons beforehand to the patients. Thank you everyone for your kind and patient hearing.
Thanks a lot, Dr. Bhalla, for a very comprehensive presentation. I'd request Dr. Charuta to come on the stage.
Yeah,
Dr. Vinod.
ask a question, I think.
Yeah, Dr. Vinod, you have, Dr. Vinod is, yeah.
Yes.
Your slit lamp calibration is 5 degree. So you can't make it 3 degree or 2 degree just blindly. If you use a smart app, like I'm using it regularly, Access Assistant is a very common one. And Graham Barrett has it here. Then there is a one from Indian doctor also. So you've got a lot of smartphone apps which can help and give a very accurate results. The study has been published, it is almost as good, with the combination is as good as you can get with any marking as marking. So combining with those two techniques are very, very important.
Yeah, I think Dr. Vinod has a very interesting point. And that is definitely, I think somebody from Nashik, from Maharashtra, he has developed a calculator. I mean,
there are a couple of those image-guided systems which are developed. One is just for the acquisition of the image, and the axis marking is by Saurabh. Saurabh Patwardhan has done it, and the other one is Swapnil. Yeah, and Swapnil Kothari has done one more, which is for the almost like an image-guided system just by a smartphone.
And on the iPhone, we got the different apps also.
Right, sir.
See, there are a few other points. I think there's a little change in plan. Dr. Vardhaman will be coming till she is able to sort out her computer issues. Sure. See, your basic IOL formula should be the Barrett toric calculator. You know, for all my routine surgeries, I do not use the Barrett Universal 2, because Barrett Universal 2 is already incorporated in Barrett toric calculator. So most of the time, many a time you find out that, you know, a patient who was not scheduled for toric IOL, you know, shows up as somebody who will benefit after toric IOL surgery. And second thing is, for routine surgeries, routine cases, not post-refractive scenario, it is not really necessary for us to measure the posterior cornea, posterior corneal astigmatism. So if you go to the Barrett toric calculator, it gives an option whether you want to use the measured posterior corneal astigmatism or assume posterior corneal astigmatism, because Dr. Barrett has an algorithm where even if you don't measure it, if you tick that particular box, it gives you a very accurate toric power calculation. And this has been shown by many articles, you know, where it has been shown that in routine cases, you really don't need to measure the posterior cornea. Of course, it is very important to do it in post-refractive surgery. Is Vardhaman, you ready?
Yeah.
Yeah. So over to you, Vardhaman.
Thank you, sir. So first of all, thank you to Dr. Arup sir for the kind invite to join sir's masterclass. Friends, I'm going to talk to you about the cataract surgery in eyes, or especially the biometry aspect in eyes with previous corneal refractive surgeries. This is a very interesting slide because this actually depicts one message, is that actually the attempt of corneal refractive surgery started about a century back. So if you see, it was in 1920 when a posterior RK was attempted by Professor Sato in Japan, and that was the real first truly attempt of doing a corneal refractive procedure. But from that time we have truly come a long way now, almost a century or more, and now we have access to very, very advanced tools. But in this whole timeline, if there was one defining moment, this was when the first LASIK was done in University of Crete in the world by my mentor, Professor Ioannis Palikaris. This is a historic video of the first ever LASIK surgery in the world. But why this is so important is that this was the first procedure which became universally accepted, and this was a procedure which actually was replicated millions of times around the world. And now, as of today, we have more than 45 to 50 million people who have undergone LASIK from 1980s to till today. And we have also Dr. Arora sir, who has been one of the pioneers in this part of the country, who has been doing corneal refractive surgery for such a long time. So those first generation of patients who had tested the miracle of LASIK in late 80s and early 90s are called as baby boomer generation. So this baby boomer generation now are the people who are becoming 55, 60, 70-year-olds who actually are coming back for cataracts around the world, and many of them who have tested the success, the magic of LASIK, the accuracy of LASIK, now have very poor intolerance for imperfections. So basically they are the ones who will come to you early for cataract surgery, but they are the ones who are intolerant to also inaccurate results. And unfortunately, in the very patients who desire the most accurate results because of their previous experience with LASIK, the IOL calculations are unfortunately least predictable. Why this happens? To understand this, let's understand how the virgin eye looks. So these are the two general formulas. I'm not going into the advancements which Dr. Arup sir has already gone through, but generally speaking, there are two different formulas. One is the regression formulas which are on the accumulated data, and the second one is the theoretical formula which works on the principle of effective lens position. This effective lens position is basically in microns, the distance between your anterior refractive surface of the cornea and the nodal refractive point on your crystalline lens, and this can also be supplemented by once you implant the intraocular lens at the same level. So it was presumed in the past that the ELP is constant for all the eyes, but as expected, of course, it was derived very soon that the ELP should be shorter on the hyperopic eyes and much longer on the myopic eyes. So if we want to predict this ELP to come to biometry, all these formulas were actually deducting their biometry calculations on the basis of a lot of parameters, and these parameters, as you can see here, vary depending on the formula that you are trying to choose. So when we are looking at this different kind of formulas, we definitely understand that all of them, they work on the principle of how your cornea is behaving. And there are three sources of errors once somebody has undergone a corneal refractive surgery, and because of these three errors, the unpredictability of the refractive or biometry outcomes of our LASIK goes haywire. So as we see here, you can see the first error is the K reading error, or the index of the refractive error, in which you can understand that if we want to actually understand the keratometry of the patient, there is a presumption that your anterior versus the posterior radius of curvature should have a ratio of 1.21. But this ratio, which should be presumed to be 1.21, goes again for a toss once you have undergone a myopic LASIK procedure. So there is an overestimation of keratometry in these formulas that leads to underestimation of biometry, and thus leading to what is called as a hyperopic surprise. And exactly the opposite thing happens in hyperopic patients. There is an underestimation of keratometry leading to overestimation of IOL power, and that leads to overestimation of the overall biometry, leading to myopic surprises. The second error is the keratometry or your instrument error, because we all know that if you want to actually know the keratometry for biometric purpose, it should be in the center of the cornea, but all these devices actually calculated 3.2 millimeters away from the center of the cornea, and then they deduce it in a way that what should be the keratometry in the center and extrapolate it. The third error, of course, is the most important error, is the formula error, and we have all seen that majority of these formulas of current generation depend on the principle of ELP. So this effective lens position prediction goes again for a toss when your prediction of keratometry, because of the error formula in the refraction, error formula in the instrument, goes for very unpredictable ELP prediction as well. And once we have that, you will see that there is an overestimation of keratometry in myopic LASIK patients that leads to underestimation of ELP, leading to again underestimation of the biometric calculation and leading to hyperopic surprises. That's the reason that if you just go by your standard IOL calculations in post LASIK patients, vast majority of them are going to land in hyperopic surprises between +1 to even going to +4. So how do we calculate the IOL power if this is the situation? One of the easiest thing that you can do if you don't have access to a lot of tools is if you have access to just a Haig's formula or Haig's formula, you can use it because this is a completely independent of keratometry. But the current generation formulas use what is called as the Aramberry Table K method. The Aramberry Table K method works on the principle of two keratometries. One is the pre-operative keratometry reading determination, which is used for ELP prediction, and the true post-operative keratometry reading measurement, which is deduced from the EKR map on the pentacam, and that is used to calculate the calculation of the IOL power with the biometry. Now this Aramberry double K method is used in variety of different formulas, and a lot of work has been done by Wong et al. In this regard, but we don't have to actually remember all these formulas all the time, and this is thanks to the compilation of all these formulas done at the ASCRS site. So if you simply go to the ASCRS website, this is free for all, you don't have to become member of ASCRS. And if you just put all your data in the current in the formula, if you have to just basically put in if the patient has undergone previous RK, LASIK or PRK, was it myopic, is it for hyperopic refractive errors, and it is going to show you a display which will show you minimum, average and maximum IOL powers for that particular patient. There have been a lot of different published data which has looked at comparison of all these formulas and have seen that OCT based on the true K formulas have been very, very promising. So I think so far we have been very successful in a way to find a solution for post-RK, post-PRK eyes, but still the post-RK eyes are still a delusion for us because the studies have shown that vast majority of these patients actually go out of ±1.5 diopters. Almost 35% of them are going to give you big surprises. And we had also published a study with my mentor in Bascom Palmer, Dr. Sonia Yu, when we have actually shown that only 65% of these eyes were within ±1.5 diopters. So this was in spite of using the intraoperative aberrometry. So this is one very typical example that I'll show. This patient had undergone a 16 incision RK in neighboring state, had now 3 to 4 grade brown cataract. I'm not going into the nuances of the cataract procedure per se, but you can see that the patient's cornea had become superbly flat now. And if we just look at different formulas, we're actually giving us a full range between 14 to 16 diopters. So this is a surgical video. I'll skip it now for the want of time. But what is it that we are doing currently for these patients? We are actually doing either intraoperative or the first day post-operative retinoscopy, and we are using Maloney's method of calculating by 1.7 times. And then in this particular patient, we actually went ahead and implanted a 17 diopters instead of 14 diopters, which was shown by ASCRS formula. And actually with this, this is the second day that we have done, and we have implanted the lens. As you can see, the patient actually achieved a very, very good outcome of only 0.5 diopters. And with this retinoscopy method, we have seen in our 38 post RKIs, which had minimum 12 incisions. So minimum 12 incisions, so 12, 16, even going beyond to even 24, 32 also. We have seen that almost 90% of them were within 1 diopter. So this is something that has really helped us to improve our outcomes for post RKIs. Now, if somebody has undergone Intacs in the past, of course, you have to treat these patients as if they have undergone a myopic LASIK and calculate in the same way. You will actually get very good outcomes because of that as well, even in patients who have keratoconus. And if the patient has undergone a phakic lens implants, as we all know, the phakic lens implants or ICL procedure are increasing by the day. The best thing about this procedure is that you don't have to make even a single change in your biometry, and you will get a very, very good biometry outcomes in these patients as well. So I'll skip the lens selections for the want of time, but I think with all these things coming together, the predictability of the IOL calculations have improved a lot in the last decade. So I would like to again thank you, Dr. Sir, for the kind invite and being here. Thank you so much. Yeah.
Dr. Charutta, you ready? Vardhaman, it was a wonderful presentation. You know, this is a topic in itself.
Thank you.
So basically, it boils down to going to the ASCARA's calculator.
Yeah.
And then, so whatever equipment, diagnostic equipment you have, you just input those data, and then it comes out with whichever formula is able to utilize those data.
Right.
And for RK also, I think that is a wonderful site. You would like to take the maximum value RK.
Right.
I think the Kane formula, all the newer artificial intelligence formulas also do extremely well. Kane formula, EVO formula.
Absolutely.
And,
yes, true, sir. Yes. Yes. Yes.
So anybody has any questions, or sir, you would, before Charuta comes online, comes on the stage. Sir, Vinod sir, do you have any comments? Any? Yeah. We are waiting for her to start a presentation. Bala sir.
Yeah.
So probably one thing I can add is for keratoconus patients, because now a lot of patients who have keratoconus are also coming for cataract surgery. So as I said, Kane formula is the formula that you have to choose for them. You have to stick to Kane formula if somebody has undergone cross-linking or not, but it comes to you at the age of 65, you already surprisingly check that, okay, patient has keratoconus, you should stick to Kane formula for that.
I think Barrett also has added the keratoconus component to his calculator.
In this crack.
So I think these are the two good calculators that are available for keratoconus.
Right.
Vardhaman, like you had calculated by the ASCRS calculator, and that was giving power between 14 to 16 by different formulas. But what made you use Maloney's method? But you are very accurate, landing up with just 0.25.
So what made us use Maloney's method is some of our previous work in post-RK eyes, because post-RK what happens is till the time you are having up to 8 incisions, the formula which is integrated in ASCR is fairly accurate. But once you go beyond 8 incisions, 12, 16 and beyond, the corneal, the shape, dynamics, they change too much. And this current generation of even ASCRS integrated formulas are not able to give very good outcomes. So we had published a study where we actually used the intraoperative also aberrometry to actually understand, and that also becomes very confused because of all these aberrations which are coming from everywhere. So we had shown that only 65% of them, when you have 12 or more incisions, were within 1.5 diopters. So that led us to actually understand what can be done. So what we do currently is either intraoperative or the first day postoperative also one can do. You can do a nice retinoscopy, and that gives a fairly good outcomes for these patients. Yeah. Thank you.
Okay, Dr. Charuta.
A very good afternoon to everyone. At the outset, I want to thank AIOS Scientific Committee and Dr. Arup Chakrabarty. He's such a fantastic teacher that he's still guiding us and mentoring us into evolving as good speakers and good teachers as well. So it is the festival of Navratri, and the goddess Lakshmi, worship, the 9 days of Navratri, we worship 9 forms of Durga, and she symbolizes awakening of our inner paths. And I want to say that we need to refine our inner clarity through these 9 forms. And modern cataract surgery refines a patient's outer clarity as well, most critically through an adequate IOL power calculation. Now, a lot of it has been said so far. Of course, there is we cannot stress less on patients' expectations, and no longer is cataract surgery a simple surgery, and high precision biometry and accurate power calculation is paramount. So this is a 50-year-old journey of IOL power formulas. And we began with Fayadrov and SRK in the 1970s and 80s. And the important thing to note here is Fayadrov, even at that point, had already said that effective lens position is what is important. And then we moved through the 90s and then come to 4th generation options like Haigis, Olsen in the 2000s. And now the last decade has brought us AI-driven formulas, which we have not yet covered so far. So I'm going to skip through by slides which are a repetition, but drive straight to the newer modalities, that is AI-driven formulas, Hill, RBF, EVO and Kane, etc., which show how biometry has evolved from empirical rules to intelligent and data-driven procedures. So this slide is grouping IOL formulas by both generation and method. We are progressing initially from the first generation regression formulas like the SRK through 3rd and 4th generation optical models, and today's data-driven and AI formulas such as Hill, RBF and Kane. Now across the bottom you will see a parallel classification, that is simple regression models, AI, optical versions, ray tracing, which is a very exciting model, which we will see later, and hybrid approaches. Now these are showing how calculation has actually evolved from basic statistics to complex physics and machine learning. Now Post-refractive IOL power calculation formulas I'm going to skip because Dr. Vardhaman has very elegantly covered these.
Or they can use the sum of secant XLA. So they cannot be interchanged. So usually this will give you.
So when we look at the Barrett's 1 and 2, we need to understand that it is expecting that we calculate a sum of the segmental axial length. Now this is very difficult in most settings and demands precise optical profile of the IOL to be known. And many a times obviously companies are not going to share these precise. However, by and large, Barrett's Universal 2 is very popular and also is very accurate in most cases. Other formulas, newer formulas such as Olsen are less accurate in shorter axial length, and 22 millimeters or lesser require implantation of, and those which require implantation of more than 30 diopters. So Barrett's Universal 2 may work for these axial lengths. So among the eyes with prior myopic LASIK, the new Sharma-Cook formula has given the lowest mean absolute error and the highest proportion of within half a diopter, which is slightly ahead of Barrett's True K, and it's clearly outperforming Sharma's PL and Haig's L. Another challenging, of course, post-refractive eyes we have seen, and myopic LASIK and hyperopic LASIK. Again, what I wanted to explain over here is values that represent effective keratometric index, which is used by keratometers, but not actually the true tissue index. And we see that in, although we have assumed the true tissue index is 1.37, assumed is around 1.3375. Once the patient undergoes myopic ablation, the average reduces to 1.32, and hyperopic it increases. So the direction of change is actually decreasing and increasing in myopic and hyperopic respectively, although we are actually now going to true K, posterior, the measured true posterior K instead of these estimations. Now Scheimpflug and OCT systems, anti-segment OCT systems measure the posterior cornea directly, which I mentioned, and the newer KCR2 swept source OCT offers very wide, the fastest and most repeatable mapping. But of course it is impossible to have entire armamentarium to our at our beck and call, and these newer formulas are also of importance because very short, very long post-PRK eyes, they come to our rescue. So if we see that in the advances in the optical biometry, the partial coherence interferometry scans and the other OLCLI and OLCR have actually dramatically changed and improved the accuracy. And in fact, IOL Master 700 itself over its 500 version has given almost a 2% improved performance in its predictions. So multi-device integration has also been done. For example, when I want a more accurate keratometry and I am using 2 or 3 devices, it is not a great, if we see that how these devices actually measure keratometry is very different from machine to machine. Even between IOL Master 500 and 700 there is a lot of difference. So 500 is actually measuring only 6 points, whereas 700 is 18 points. Hack Street Lenstar measures in 1.8 to 2.2 millimeter zones. Therefore, in a study which was done comparing whether when you can mix and match, the one take home point if I want you to remember at the end of this presentation is this, that the variation or the of accuracy is very high when you mix and match. If you put IOL Master readings keratometry into a Galilei, then you are going to get a error. And the variation of error is very high from 0.27 accuracy to up to 2 diopters of error can happen. So don't mix and match, stick to the machine that is taking the keratometry and enter in that formula itself, because we are going for, every machine in itself is going for newer and newer technologies of biometry, IOL power calculation. Now we see manual keratometry, automated and Lenstar are actually not measuring the posterior K, whereas all the other newer machines have inbuilt posterior keratometry measurement, which has been shown to be very important. Now this is one of the things that I wanted to come harp on, which has not been spoken of so far. So basically Hill RBF formula is now in its current version 3.0. So this is like sci-fi, and they have actually followed all the steps. They had started off with a subset of only 600 patients, entered the values, developed a mathematical calculation model of IOL prediction, and there has this most recent version with almost 6,000 patients has no bounds of indications for normal eyes undergoing cataract surgery. So the accuracy has been, they have kept working on the accuracy by increasing their data set, and we know that an artificial intelligence model can only be as intelligent as the data that you feed it. So the current model was in fact developed because one of the users said that we are in Caucasians, we are still not happy with your previous formula. So they've gone on and included a lot, and the recent study in the Journal of Cataract Refractive Surgery concluded that this third version of Hill RBF has has the lowest of the standard deviations of all the formulae, and also the best 0.5 diopter accuracy. Now another thing that I would urge everyone to do is to complete your record and go online on this for this personalized A constant calculation. So this is the LCO calculator which is available online, and the very nice thing that they have done for all of us is that they have made it into an Excel sheet which automatically calculates, and it is automatically evaluated for outliers. So you need not actually go ahead and filter your own results. Enter everything that you have, it will calculate your own lens constant for you. Artificial intelligence pipelines which have end-to-end prediction models have also been developed. Now the optical quality described in terms of the visual stream of the optical transfer function is the metric that has been shown to correlate with the logmar visual acuity. So this is their language. In very simple terms, it is the OTF which we are talking about. Now OTF is the language in which the model is talking, and what we are talking about is the logmar visual acuity. But basically for the patient, it is the one which is the crispest image that you want. So you have these patients who are talking about not clear vision, mabbu, something difficulty in vision, and this is what they are talking about. So now these customized ray tracing optimization have been developed, and they are correlating natural higher order aberrations with multiple spherocylindrical correlations. And these are very useful, especially in the weird cases where you have higher order aberrations very high, or you have irregular astigmatism such as in cases of keratoconus post cross-linking. Now it is seen that in these corneas with greater higher order aberration and a lower OTF, almost zero experienced a greater improvement with this method. Now again we have a lot of machine learning happening. There are cloud-based calculators which are available, and ray tracing and full eye models also that are available. Intraoperative aberrometry, Dr. Balla sir has already very elegantly and beautifully covered in details. So I am not going to repeat that. Now basically how do we embed this new technology cost effectively? I would say that initially till their data set is large enough, go ahead and only use the online calculators that are available. Don't invest in it immediately. And these are all emerging trends, and such as light adjustable IOLs and quantum sensors, etc. Time will tell. There is something called the test of time. If they stand it, then it's easier for us to adapt it and more cost effective as well. So at the end I would say that the take home would be that AI cloud driven would probably give us ultimate fulfillment. As mentioned, Hill RBF has actually tackled a lot of these, and the newer data driven refinements are actually helping us with the weird cases, with the outliers, and hopefully there will be a single unit that is available for us so that we can just enter the data and let the machine decide which is the best calculator and which is the best power, more accurate and best for the patient. Thank you very much.
For covering the entire gamut of changes that are coming up and the recent advances that have taken place in the field. And am I audible? Can I get me on the screen? So I'll be talking about some special situations like the previous speakers have spoken about. What we have learned is, the IOL prediction has become extremely accurate for routine eyes. But there are certain situations, certain cohorts of patients where we are lagging behind. We are not able to deliver, that 90% result within prediction error of 0.5 diopters. So one of that happens to be the post-vitrectomy situations. Where are the hurdles? These situations, many of these conditions, we find it difficult to measure the axial length, particularly when there is a silicone oil field in the posterior segment. And once we get the IOL power, get the axial length, what are the best formula that should be used for these situations? And then what is the best power? Do we have to modify the intraocular lens power, particularly in patients who have silicone oil still in the posterior segment? And finally, what is the best type of intraocular lens that will give us the most optimal results? The difficulties in axial length measurement is the most important cause of error in IOL power calculation. So in silicone oil filled eyes, if you are using immersion A-scan, there will be an overestimation of the axial length. And if you are measuring the axial length in a patient with a macular edema using ultrasonic biometry, again, there will be an underestimation. Likewise, in a patient with a bullous regmentinous RD, if you are using an optical biometry, then again there is an underestimation that is going to happen. So how do I sort out this problem in my practice? When a patient with a posterior segment pathology comes for posterior segment surgery, first thing we do is we perform the biometry for the patient. Ideally optical biometry if it is possible, and in certain situations where it is not feasible, then acoustic or the ultrasound biometry. And the results are archived in the hospital and a copy is given to the patient, so that wherever the patient goes later on, patient has got the biometry, pre-vitrectomy biometry available with him. So challenge happens when a patient comes to us, a fresh patient who has already got a cataract with silicone oil in the posterior segment. So I do an optical biometry in those situations. That sorts out the problem. However, in certain situations, for example, a patient who has a very advanced total cataract, thick posterior subcapsular cataract, patient cannot fix it. Optical biometry is not possible. So then I will be resorting to acoustic biometry, and herein the problem lies. See, the silicone oil in the posterior segment reduces the velocity of sound in the posterior segment. So you also get poor retinal echoes, and because if there may be multiple bubbles of silicone oil in the posterior segment, so you may have a shifting or deduplication of the echoes. So ultimately you have, like for example here, these are the echoes from the retina, which is very, I don't know, am I visible on the screen? I'm not able to get my here. Okay. So you need to convert the apparent axial length the true axial length. So now here is a situation. So now here I have a situation where the patient has silicone oil in the posterior segment, and we have used a velocity of 1532 for all segments. This machine has got multiple gates, so you can measure the anterior chamber depth, lens thickness, posterior segment thickness, posterior segment length separately, and using a velocity of 1532. So you get a total axial length of 36.28 millimeters. This is the apparent axial length that has to be converted into the true axial length, and you need to know the velocity of the viscosity of the silicone oil that has been used in that particular case. So for a silicone oil with a viscosity of 1000 centistrokes, 980 meters per second is the sound velocity. For 5000 centistrokes, 1040. So depending upon the velocity of the silicone oil, of sound in the silicone oil, the axial length can be, the distances measured can be adjusted, and ultimately you see that the true axial length is only 25.69, and the apparent axial length was 36.28, and that was actually confirmed by a optical biometry that was done, which again gave an axial length of 25.7 millimeters. But in certain situations, you may not know what exactly was the viscosity of the silicone oil in the posterior segment. Patient who has walked in from outside. So so I would be using, taking a chance, and you would be using various constants. Say, for example, if it is silicone oil of 1300 centistrokes, if the initial surgeon tells me, then I would use a factor of 0.71 and multiply this with the axial length. So these are the problems with silicone oil filled eyes. There are multiple bubbles, And if you have a problem in doing biometry, ultrasonic biometry for these patients, make these patients sit up, in this position, so that, you don't have the patient, the sound beam does not have to encounter multiple interfaces. Don't do it in the supine position, do it in the patient, with the patient sitting up. Now, sometimes, all said and done, if nothing works out, you cannot measure the, ultrasonic biometry also doesn't give an axial length. There are reports in the literature where CT scan has been performed, MRI has been done. These are very expensive. Some of them may be very accurate, but they are not feasible. We have taken axial length of the fellow eye or a standard power. So I don't think this is really advisable, but these are the things which you see in the literature. And after silicone oil removal, like after the silicone oil is removed, you refract the patient and then find out what is the best IOL power for the patient. Now, this is a patient where silicone oil has been removed and the intraoperative biometry was done. Eye was pressurized with an infusion and then appropriate IOL power was calculated. So this is another another thing that could be easily done. The same person, Dr. Saurabh Padwardhan, I think, who has done that particular device you're talking about, So he, their study has suggested that if you do the retinoscopy after removal of the silicone oil on the surgical table and multiply the retinoscopy value by this factor, you get the IOL power and implant that particular IOL. So there are various other options, various other studies, which almost suggest the same thing, multiply by 2.01, multiply by 1.75. So now you have got the axial length of the particular patient, difficult with lot of difficulty. Now how do you choose the intraocular lens power for this patient? Now, these patients have got silicone oil in the posterior segment, and silicone oil has a higher refractive index than vitreous. So this means, it converts the eye into a hyperopic refractive error situation. So you need to adjust the intraocular lens power. Now, it has been shown that, the hyperopic changes that happen, it depends upon the shape of the lens. If you have a biconvex lens with a lot of convexity on the posterior curvature, you have a maximum hyperopic shift. If you have a plano-convex lens, unfortunately, plano-convex lenses are not available in the foldable format now, or a meniscus lens where the posterior surface is concave facing towards the retina, that reduces the postoperative error. So, how do we look for the lens power? How do we fix the lens power? This situation happens when the posterior segment surgeon wants a silicone and fill the posterior segment. The retina requires the silicone oil, and you have done an intraocular lens. So if I'm using a biconvex lens for this patient, and this is what we routinely use, for any lens more than 20 diopter, you have to add 8 diopters. Say, for example, if my IOL master gives me a lens power of 20 diopters, in this patient, I'll be using 28 diopter IOL. Otherwise, the patient will have a bad hyperopic shift. And once the silicone oil has to be removed, we remove the silicone oil and patient will have a myopic shift. So this has to be explained to the patient beforehand. Proper counseling has to be done. And that can be treated with maybe, IOL exchange, or it can be laser, or it can be treated with corneal refractive procedure. And so, but IOL power adjustment has to be made when you have silicone oil fill in the posterior segment. So this has been amply proved by many studies, what exactly is the quantum of IOL power that you need to modify. And as regards formulas, now newer and newer formulas have been coming up. So now, which formula to use for which situation? Again, I scan the literature and this is what we follow. See, now we have patients undergoing vitrectomy with very good prognosis. Macular hole, epiretinal membrane, vitreous hemorrhage, otherwise normal posterior segment. So postoperatively, it is really necessary for us to give a very accurate and precise postoperative outcome for these patients. So each and every aspect of your calculation exercise is important. Now, for patients who have, if you are performing, phacoemulsification patients who have undergone a vitrectomy, so this particular study compared the newer formulas and the traditional formulas, and found out that the traditional formulas, if you have done a Weinkoch adjustment for the axial length, and the newer formulas, they do pretty well. Now, if you are combining phacoemulsification with silicone oil removal, in that case, the EVO formula also does extremely well, but most of the newer generation formulas also do pretty much well. And situations where epiretinal membrane peeling and for that vitrectomy has been done, phaco plus vitrectomy. So here, the Kane formula has done extremely well, but that does not mean the other formulas cannot be used. Kane formula has done extremely well, and Barrett Universal 2 and Heal RBF. So what I do in these situations is I calculate IOL power using all the formulas, and most of the time the formulas tell me the same result. If there is a change in the result, then I use the Kane formula because it has been proved for more than 5 years that it has given good results. So friends, I think how much time do we have? 42, yeah. So so cataract surgery, IOL implantation in eyes with posterior segment conditions are no longer a very challenging situation. Is no longer has become very demanding. Like unlike in the previous days, now vitrectomy is being done for very good prognosis eyes. So we have to make sure that use the best technology, best surgical technique, best strategy for IOL calculation for these patients. And in certain patients, of course, in spite of a best effort, if the patient has a very disorganized posterior segment, your best results may not really be very well appreciated by the patient. So in spite of that, you must use the latest technology techniques, use the current concepts and the newer formulas to give you the best results. So this is the end of my talk on phaco in vitrectomized eyes. Any questions on this? Mohan Rajan is here. Mohan? Can you put me on the screen again for my last talk? Anybody wants to add anything to this discussion so far? Is Dr. Mohan Rajan here? He is supposed to give a keynote address. Can you put me on the screen? Actually, my wife is a VR surgeon, so we have been doing these combined cases for maybe the last 30 years. So we have done a couple of hundreds of cases. And so now, the final topic is phaco in myopic patients. So we started about 10 minutes late. Huh? Sir, we started about 10 minutes late. Yeah. So phaco in myopic eyes and phaco in hypermetropic eyes. So basically, see in phaco in the myopic eyes, there are a few additional issues that crop up. What is the best way to do the biometry? What IOL formula one selects? And what is the IOL power? Do we have to address the intraocular lens power? In addition to the surgical nuances and IOL considerations for these patients. So the most important problem with these high myopia patients is the presence of posterior staph.
Short and long.
Your topic, that topic was for the next session.
Phaco and short.
Yeah. Okay, so okay, so I think there will be there is some overlap. I have started out that So this is actually see in myopic patients the most common problem that you encountered is a posterior staphyloma, as you see here, and many a time the fovea may not lie at the pit of the staphyloma; it may be lying on the wall. So how common is posterior staphyloma? If you see this particular study, as the axial length increases, goes to 33.5 and beyond, the staphyloma is seen in 71.43% of all the patients. So it is quite a significant problem. So if we are using an immersion ultrasound measurement, and if you are measuring up to the bottom of the staphyloma, you are going to get an abnormally long axial length. So you should use a B-mode guided biometry if it is available in the B-scal unit, so that the A-scan is taken from the central vector axis. And of course, the best option would be to perform in ultrasonic optical biometry for this patient. So because the patient fixates on the light and you know that you're measuring the refractive axial length. So what are the formulas that are popular for the extremes of axial length? See, for the routine axial length, any new formula is going to do well. There's not much of a choice for us. However, formulas perform less reliably at extremes of axial length. Short eyes, they overestimate the required IOL power, resulting in a myopic error. Long eyes usually result in a hyperopic error. And these, these changes, these patients with high myopia or high hypermetropia are not very uncommon. See, less than 22 millimeter length patients, axial length patients are seen about 4 to 7% of the patients, and more than 26 millimeter axial length are seen in 8 to 6% of 16% of our cataract patients. So, if you are measuring the axial length using ultrasonic biometry, you have to use a if you are using these traditional formulas, Holiday 1 or Hygie's, SRKT, offer Q, and if I measure the axial length using optical biometry usually overestimates the axial length. So you have to modify the axial length by a Van Gogh factor, and this factor varies from formula to formula. So you have to modify the axial length to get at the true axial length, and before you use the standard formulas. Now, if you are using the current formulas, these are the new formulas, so there you don't really need to make this Van Gogh adjustment, and you can use these formulas as such. So which are the good formulas for this? So, for example, this particular study published last year, where axial length was more than 28 millimeter, compared the Barrett Universal to EVO, Kane, Hill, RBF against the older formulas, and found that Hill, RBF and Kane formula are better choices for these eyes. And again, this is another formula, another paper which is just published in October. I mean, it has been published online. So they found out that again the Van Gogh adjusted axial length for eyes more than 25 millimeter, and the newer formulas, all the formulas have done quite well for these eyes. So basically, it boils down to the use of newer formulas. And if you are not using the newer formula, then you have to modify the axial length by using the Van Gogh modification. So you get at the axial length, okay? And now the question of, what exactly the IOL part that is to be used. See, after a scleral buckling, the axial length usually increases by 1 millimeter. Anterior chamber depth never changes. But since we are measuring the effective lens position based upon the axial length and the K reading, you get a lens which is sitting deeper in the eye, so which predicts a higher power. So this has to be taken into account. So if you are dealing with a patient who requests a myopia patient with more than 14 diopter, you need to reduce the IOL power by a factor of 0.5 diopter. So this is about high myopia. And then now in the short eyes, the constants are a little different. In the short eyes, hypermetropic eyes, less than 22 millimeters, the small axial length combined with high power can cause a large refractive surprise with a minimal shift in the effective lens position. And as I mentioned earlier in my previous talk, the tolerance for IOLs with higher power is higher. 30 diopter, for example, it could be it could be 29 diopter or 31 diopter. So that can also give rise to refractive surprises in the postoperative period. So basically, once you have got the axial length right, so which is the best formula for patients with an axial length less than 22 millimeter. So this particular, again, it shows that the Kane formula, Pearl DGS formula have done extremely well. So basically, you have to use an optical biometer to measure the axial length for these eyes, and use a newer formula, Kane formula or Pearl DGS formula, to get you the best outcome. So I think this is how, I tackle high myopia patients and high hypermetropia patients in my practice. So thanks a lot for your kind attention. And if Mohan Rajan is not here, then in that case, maybe if any panelists want to make any comments or any comments from the audience, you need to add something. Yeah. Okay. So in that case, thank you very much for being here for this program. And I would also like to thank the panelists for taking so much time and preparing extensively for the talks. Thank you very much.
Thank you, sir, for putting up a great course together. Thank you. I think we'll have a
We have to take a picture, isn't it? Is the official photographer here or?